Rebecca Cooper.
Thanks so much, and thank you for giving up your time to come along today. So, Lord Darzi, as a public health consultant, I don't hold it against you that you chose to become a surgeon, but I am glad that you've seen the light. Welcome to the good side. Thank you. So, as Deirdre says, I just wanted to pick up around the prevention agenda and some of the more strategic aspects of it. So in your report, you refer to the breakup of Public Health England during the pandemic, as you've already stated. And the wording of your report suggests that you don't think that this was potentially the most beneficial action for public health in the UK. So could I ask your thoughts on the subsequent setup of public health departments in the UK? And for clarity, obviously you've referred to the Health Security Agency already. We have the public health teams in local government, and we have OHID sitting in the Department of Health and Social Care. And specifically, and I hear you when you talk about Professor Chris Whitty, and he's absolutely excellent, but the Chief Medical Officer does have a specific remit. So that remit aside, do you think we're now well served with strategic public health leadership? And does your report give any insight as to how we might improve going forward?
Thank you. My report was diagnostic. You appreciate that. It wasn't any sets of recommendations. I'm sure the 10-year plan will have its own recommendations. I think the point I was making is dissolving a structure in the midst of a pandemic. I was being a bit cynical, if I could just say that. I don't understand why the reasons at the time, but I'm sure there were good reasons for it. I think Health Security Agency is doing its job very well. I think what I was trying to say is we have the Department of Health and Social Care and we have the NHS. I think what we need to think through, what are the powerful levers that we can give at a time where we have a Chief Medical Officer with public health global expertise. How do we those levers to really drive the public health agenda within the National Health Service, considering all the strains and all the challenges we've just been discussing? Because I think secondary prevention is critical, but that is never going to happen if we're constantly chasing the big other challenges. I mean, the long list of challenges facing the National Health Service at the moment. We need to find a way of prioritising the secondary prevention and the public health agenda. That's the only. It's more of. I'd love to see more of that, and I'm sure that will happen in the 10-year plan. I have no doubt that we will see much more reinforcement of the contribution of public health.
So just to follow up, just to be clear, do you see strategic public health leadership currently sitting solely with the CMO? I mean, I know there are leaders, obviously, in OHID and the Health Security Agency and the Association of Directors of Public Health, or do you see the need perhaps for, to coin a phrase, a truth to power leadership that might need to sort of complement the CMO's role?
I have no opinion about this. I really don't. The only thing I could say, you have an amazing leadership in the CMO to drive this, and I will use him rather than create a different organisation.
Thank you, that's really useful. So just moving on a bit and looking at the general funding setup, and I know that, Tom, you've already talked around this when you've been talking about the inequalities and health resource allocation. Again, sort of reading through your report, I wondered if you wanted to comment on whether you think there's a better way to distribute funding through our health system, and specifically perhaps picking up on a couple of Ben's points around local government. Do you have any thoughts on more fully devolving resources and responsibilities for health services, perhaps to run in parallel to the planned devolution agenda for local government?
Well, I think there's been some experimentation in this area. So there was obviously the effort, Devo-Manc, as it's called, to devolve health and social care budgets to Manchester, and that's been through various different evaluations. I suppose there's a kind of question about, would you want to devolve health budgets to local authorities? I think that's what you're getting at, and there's been a long kind of tradition of people arguing for that. In this report, we look very closely at the distribution between different parts of the health system. So if you take that shift from hospital to community, having said that very loudly in 2006, for the next 18 years, we've gone in the opposite direction. So in 2006, the hospital sector accounted for 47% of spending, and by 2021, which was the last year that the data was available, it accounted for 58% of NHS spending. One of the notable changes that I think has had a very positive impact has been the mental health investment standard. And what that's done is it's protected mental health budgets. So if you look in the report, you'll see that in the first period of the 2010s, there were very, very deep cuts and reductions to mental health expenditure. That was then reversed in 2016 onwards, and you see that it's a kind of U-shaped curve, so that by the time that you get to the end of the period, we've kind of recovered back to where things had started in 2010. And the mental health investment standard basically says that mental health spending will increase at the same rate as the wider NHS budget, plus a very small, I think it's 0.6%, 0.7% each year. I do think one of the recommendations around locking in financial flows in a particular direction, that would seem to me that if we really believe in this idea of shifting from hospital to community, then we ought to be considering expanding the scope of the mental health investment standard so that we create a similar investment standard for community services and for primary care, so we stop this long-term drift of more and more resources into the acute sector. I think that would have a much more significant impact on the overall sort of pattern of services than something that was aimed at somehow changing the way that they're distributed amongst ICSs to involve local authorities. I think Ara's very clear in the report that reorganising the system again would be detrimental to its performance, and so that kind of radical reorganisation to hand it over to local authorities, I think we would see that as a largely harmful activity, but changing the financial flows to actually lock in the shift of resources so that we match our words with our actions could be very powerful, and hopefully the 10-year plan will have a look at that.
Thank you. Next question.
Yeah, thank you. So just to be clear, I think I was thinking about sort of not the old regional health authorities, because we just keep going around in circles, but perhaps the integrated care partnerships, looking at what they're able to do and what perhaps they're not doing now, and whether if we are going to be serious about sort of decentralising health alongside social care to give parity of esteem with those two areas, whether that is something that we should consider.
Also, NHS England has just devolved the specialised commissioning budgets to ICSs. So ICSs are taking on a greater and greater share, and each of them consists, it's quite complicated, of an ICB, an Integrated Care Board, which is an NHS body that is part of an integrated care partnership with local authorities. So that structure already exists. So as the scope and scale of ICSs expands, hopefully that will also be a good basis for closer working with local authorities.
Thank you.